All right, everyone. Thank you for coming. Welcome. My name is Angela Douglas. I'm the Executive Director of Healthy New Albany, and I'm thrilled to be here today. Today's topic is a heavy one, adolescent suicide. Our aim for today is to provide an opportunity to discuss this difficult topic in our community, provide families critical information and resources, and to discuss the importance of prevention. Adolescent suicide is the second leading cause of death among 10 to 24-year-olds in the United States. And sadly, it is the #1 cause of death in adolescents in Ohio. 1 in 5 adolescents have contemplated suicide, and 1 in 5 adolescents are diagnosed with mental illness, which can lead to suicide. I thank you very much for being here today to discuss this very important topic. First, I would like to extend a special welcome to Representative Mary Lightbody, Ohio House of Representatives, Franklin County, District 19. Mary and her staff are working to bring forward legislation to establish an Ohio Suicide Prevention Coalition program to track and analyze suicide data and develop programs and interventions. Thank you, Mary, for your very important work. Thank you also to Christy Darren with Sycamore Wellness, who sponsored our lunch today. There's information for Sycamore Wellness in your information packet, whether you're here in hard copy or digital. In addition to our panel today, I would like to introduce you to a couple of local individuals that are actively helping families and adolescents in our community with therapy and various other mental and behavioral health services. In your packets, both digital and hard copy, there's various information and resources provided as well. At the end of the session, I will introduce to you our NAPLS Wellbeing Community Liaison, Diane Herman, as well as James Gillis from Integra Wellness. But right now, Sarah Underhill from Wellbeing Connection, she actually has to leave this morning. So we want to make sure that you understand the work that she's doing in the community. So before she goes, we're going to hand it over to her for just a moment to share about the great work that Sarah and the Wellbeing Connection is doing.
Hi, thank you so much, Angela, for having me here. I just so appreciate it. And yes, I have a standing therapy appointment every week at 1 on Wednesdays, and I protect that, so I need to leave. But I just want to share with you about the Wellbeing Connection. I and a friend, Diane Herman, founded this about a year ago, and I am the executive director, and it is a new nonprofit. We are looking to bring resources, education, support, and reduction of stigma of mental health to our community. And so far we have had a really great year. We have started several programs, CARE, which is compassion and resiliency experience, which is yoga and meditation, and really just very gentle to help with stress reduction. And we've seen a lot of people really find help from that. Also, it can help with addiction as well. We help with NAMI, who has a family support group in New Albany, which is amazing. Rochelle Martin is the leader, who's the executive director of NAMI Franklin County, and she is amazing, and people have really found help for their families through that support group. And Parenting Kids with Special Needs, a support group that we have once a month, has just been amazing. I myself have kids with special needs, and so it was kind of my baby project at the beginning that I wanted to start, because it can be very difficult as a parent to have a kid with a special need. And we had it last night, and we had a new member whose daughter just got diagnosed with autism, and we were all we happen to be mamas, although we welcome men too. We just covered her with love, and it's exactly what my vision for that was. So we have a lot of other programs.
Okay,
Good.
can you start over?
Sure.
Sorry about that.
We'll go again. I would be happy to introduce our panelists. Melissa Werby-Arnold is the CEO of the Ohio Chapter, American Academy of Pediatrics. She serves as the head of Ohio AAP Foundation. She also serves as the chair for the Executive Director Steering Committee for National AAP. In 2016, Melissa was named a finalist for Healthcare CEO of the Year from Columbus CEO, and in 2015 was recognized by the Association Forum as a National 40 Under 40 honoree. Thank you for being here. Next, we have Dr. Gittleman. He's a pediatric emergency medicine physician and co-directs the Comprehensive Children's Injury Center at Cincinnati Children's Hospital. His research has focused on the #1 cause of morbidity and mortality to children, intentional and unintentional injury. His findings are that the majority of these injuries are preventable, and he would like to reduce them so children may grow up to live happy, this makes me cry, healthy and productive lives. Thank you for being here. And finally, Dr. Ackerman is a child psychologist and the suicide prevention coordinator for the Center for Suicide Prevention and Research at Nationwide Children's Hospital. Dr. Ackerman and his team have provided training to many schools throughout central and southeastern Ohio using an enhanced Signs of Suicide, SOS, prevention programming model. Dr. Ackerman has a strong research interest in risk factors and treatments for mood disorders and suicide. His research focuses on neurocognitive risk factors for youth suicidal behavior. Thank you so much for being here. We're going to start with a presentation by Ohio AAP and the Store It Safe program. You'll see the slides on your screen, and in the room you'll be able to see them as well. If you could hit the lights. Thank you.
Okay, so I'm going to kick it off. You just heard, I'm Melissa Werby-Arnold, CEO of the chapter, and Dr. Gittleman and I will kind of tag team this a little bit and kind of talk about our who we are as well as our Store It Safe program. So who we are, we're actually very fortunate in the state of Ohio to have 8 children's hospitals, which is just sort of unheard of for out in the middle in the Midwest. But that means that we are also the 4th largest chapter of the American Academy of Pediatrics in the country. We have Nationwide Children's right here in the Central Ohio region, and are stronger for it. So we're able to serve about 2,900 pediatricians in training, otherwise known as residents or subspecialists. And we are actually separately incorporated in the state of Ohio from our national organization. So while a lot of things align, I think later when Dr. Gittleman's talking, you might hear a little bit about sometimes when the Ohio chapter doesn't necessarily align with our national organization. So we are, so the next slide is, so we have what we identified as our sort of unique brand. So what makes us a little different from other groups, and what we feel makes us different is we really put passion and ideas into action to advocate for Ohio's children. So we do that through lots of different programs. I go to our next slide, which really kind of shows some of our outcomes from last year. So over 1 million children in Ohio directly served through our programs. We have about 17 active quality improvement programs right now in topics from childhood obesity. We'll talk today about mental health, lead screening, injury prevention, oral health, early literacy. If you can think of a child health topic, we probably have a program on that. So we spend a lot of time doing programming in those areas for pediatricians, also a lot of direct outreach to families when we can, and then a lot of time down the State House advocating for children. I'm going to turn it over to Dr. Gittleman to talk about this particular program.
Thank you. I'm excited to be here. This is great. I didn't mean to start off with a quiz, but let me just ask you, how many of you, looking at the slide, what do you think are the top 2 causes of death to teenagers? Just scream it out. Sorry to those that are not here and online. Great. So a lot of people don't realize unintentional injuries are the number 1 cause of death to kids. Unfortunately, number 2 for the teenage population is suicides. So the graph on your left is the CDC's, every year they put out the top causes of death. You can see from 1 to 44 years of age, it is unintentional injuries. And for the teenage population, it's suicide. But if you look at the graph on the right, 72.4% of teenage deaths are because of these 2 mechanisms. Right? Can you imagine if I said tomorrow that Zika virus is causing 72% of the deaths to teenagers? We'd be outraged. We'd sit there and say, we need to do something about this. This is catastrophic. And so that's kind of one of the reasons why we want to talk about suicide today, because for teenagers, this is a completely preventable cause of death. So just to look at some numbers, I always think it's good to understand that, is this really a problem? Once you decide that it's a problem, then you could say, well, who's at risk for it and what are some interventions we can do for it? And unfortunately, the suicide numbers and depression numbers have just been increasing drastically over the last several years. So if you take a look, deaths in and of themselves are up 49% since 2013. And unfortunately, there's an 80% increase in the kids less than 14 years of age. So I used to, in my emergency room, only see kids that would come in that were 16, 17, 18. Now I see 8, 9, 10-year-olds that are coming in with suicidal ideation or causing lethality. For non-fatal injuries, our ED visits are up. If this is not a typo, 329%. So in my emergency room where I work, when I was just starting out a long time ago, we used to see maybe 600 to 800 visits for a psychiatric evaluation. We see about 600 to 800 every month now in our emergency room. It's actually the number 1 cause for hospitalization in our hospital, it's Cincinnati Children's Hospital, and I'm sure it's probably close to that at Nationwide as well. If you look at all mental health disorders, they're up 60%. And then if you think of just, they did a youth behavioral risk survey, and they found, just asking anonymously teenagers, 8.9% of teenagers that were surveyed attempted suicide, and close to 19% have had thoughts of suicidal ideation. And the reason we're going to talk a little bit about how do we prevent this, and we just wanted to bring up about suicidal ideation and some of the risks. Well, the presence of a firearm in the home increases that risk, and we'll talk a little bit more about why that is later on. But 82% of those that completed suicide completed it from a firearm that was in their house, right? And unfortunately, 25% of teenagers at any time could be depressed. So, you know, I have kids that are past teenage years now, but at any time, if you think about it, you say, how was your day? About a quarter of the time, one of the kids is going to say, yeah, it's miserable, I'm depressed, which is really sad. The next problem is kids are incredibly impulsive. So we always say that younger kids are experimental, they don't really know, and they always try and get into things. The teenagers are incredibly impulsive. So if you take a look at this slide, they interviewed survivors of kids that attempted suicide. 25% made an attempt within 5 minutes, 50% within 20 minutes, and 71% within 1 hour. And most of the decisions were within an hour of some kind of crisis. So boy breaks up with his girlfriend, goes home, says, I don't want to live anymore. Within 1 hour, 71% of kids are going to try and commit suicide. So again, and I'm going to keep going back to this, and Melissa's going to talk a little more about this, decreasing the lethal means in the home increases the likelihood that they won't complete the suicide thoughts. So what are some common triggers? And I think Dr. Ackerman might talk a little more about this, but triggers, as I'm sure many of you can know, so bullying is always kind of a trigger with the teenage population. Usually it's between peers. Often it occurs over time. It's not just a one-time deal. These kids are continually bullied. It can lead to lower school performance, detachment from others. Internet usage has been shown to increase the thoughts for triggers for suicidal ideation. Some have shown that internet usage of greater than 5 hours is actually kind of a predictor. Increases in stress and at home. And unfortunately, all of us, just think of yourself, how you're trying to deal with this pandemic and kind of the angst that you have personally. Imagine an impulsive teenager and how they're dealing on this. It is a significant stress. And unfortunately, these evaluations for psychiatric thoughts and suicidal ideation is only increasing during this time. And then recent attempts by self or others. So as you can imagine, we got together as the Ohio AAP, and just as Melissa said, we try and find people's passions and how do we kind of put those into action. So we all got together and said, you know what, suicidal ideation is a major problem and we need to work on that. But one thing that we know we can do is decreasing the lethal means of a kid having access to them. And so we said, what can we do to try and think about firearms and how do we have discussions about this at a statewide level? And so we said, it's such a polar discussion. I can tell you the American Academy of Pediatrics, they will have on their website that says the safest home is a home without a firearm. You talk to Buckeye Firearm or NRA or firearm advocates, they will say the safest home is a home with a firearm, right? So how do we start these conversations? And we decided, you know what, the best way to do this, let's get everyone in a room together and let's talk about it. Because it was really interesting to learn from each other as to there's got to be some common messaging. We all actually agree on certain things, and what can that look like? So we said to everyone that we're going to have common goals. We want to come up with a message that we can all agree upon. And we also said that we only wanted to address two aspects. One, unintentional injuries to children, which is usually under 5 years of age, and then suicide by firearm with teenagers. And what would that message be? Well, we learned a lot from our group. One was, a lot of people didn't understand, why do pediatricians even bring this up in counseling? Right. Another question was, what do we do with this information? How does this pertain to the safety of my child? Shouldn't others be talking about this? And so, and then also, when we keep records, where do those records go? So all of these discussions were really helpful for us as healthcare providers, and also for others on the other side that were NRA and Buckeye Firearm hearing why we're doing this. And it was really important. Well, the first thing is that we learned was that they understand why we're having these discussions, but they want us to frame it in the discussions of other safety, which is what we do as pediatricians. We have discussions about anticipatory guidance. We know about the development of children. We know what the data shows. And as a result, we want to tell that to our parents. So that's why we talk about pool safety. That's why we talk about locking up medications. That's why we talk about crossing street, bicycle helmets. We know what's going to be going on up with the age of the child in development. So we want to have those discussions. Well, some might say, well, do these discussions work? I've done a lot of research in this area, and they do. I mean, look, there's two parts of the discussion. One is education. So sometimes families just didn't know about it. And so it's something we're bringing to them. Like, for example, in mid-2010s, we used to say back to sleep program for safe sleep for little children. Well, the AAP came up with more guidelines. Now it's not only back to sleep, it's sleep in your own environment in a crib with nothing else there. When those recommendations came out, a lot of people didn't know about these new recommendations. So sometimes all we're doing is educating families so that they can make better decisions. Sometimes families know, and they just really need to get some understanding of how do we change their behavior. So I can show you that when we have research looking at, if we have counseling about firearms from a pediatrician office, about 62% improved their storage of the firearm compared to only 27% of controls. Similarly, when we've looked at it in the emergency room setting, more than 60% changed their behavior as opposed to 0% of controls. So education and counseling make a difference. However, as we just spoke about, you can counsel families, but we're talking about counseling the families, but who's kind of the one we're concerned about? It's the teenager. So we just said teenagers are incredibly impulsive. So counseling works to some extent, but having a barrier works to a greater extent. So if you look at this slide, you can see it's the same as with pool safety, right? So we have counseling about don't let your toddlers go near that pool. But then what else do? We put four-sided fencing around it because we need to improve the barrier, the protection, so that we're not having the injuries that we're seeing. It's the same thing for firearms. So these are the discussions that we had was, boy, we can counsel and we can increase people's knowledge, but we really need to talk about barrier. And so that's where we all decided that our message has to be store it safe. And we wanted to come up with, this is a message that we can get around. The people that were extreme gun advocates, they said, if a firearm is not on my possession, it should be locked up. And we said, we understand that a firearm could be in the home, but it should be locked up. So we all agreed that this is a message that we could rally around. So we looked at it and we said, well, we're going to trial a project. We're going to give it out in 6 nationwide children's practices. We're going to look at kids that were under 5 years of age, and we're going to give out gun locks. And we're going to see if counseling and giving out a gun lock can make a significant difference. And what was great was we distributed about over 900 gun boxes from pediatric practices, and we surveyed at least more than 300 in return. And we found that about 50% of families learned something new. So as I said, there's an education aspect. So about 50% of families learn something. So if we do anything, allowing them to make the best decisions because they're the most informed is important. But not only did the education work, by giving out the gun boxes, more than about 81% said they were going to use it. And if they didn't use it, they'd give it to a family member or relative that would use it. And so we decided, boy, this was a pretty successful project. We were counseling families, they were using gun boxes, and we were able to store it safely. So how do we do this now for the older population? So we decided that we wanted to expand this to teenagers, which brings us here today. And so we did a project now with, was funded through the EMS grant, and we had 4 practices. We had a total of children of about 31,000, and 23,000 children were from NCH.
So as we move basically from our younger children, we move to our older children. So what we called our move from unintentional injury to intentional injury. And I will say, as a parent of 2 teenagers myself, this was probably the scariest part of this program. I was really comfortable talking about the younger kids. I was comfortable talking about the gun boxes. When we started getting into suicide, which I know is what we really want to focus on, it was pretty scary for me. And I think one of the best discussions we had was really thinking this through from the barrier method that Dr. Gittleman just talked about. So we knew we needed to have a barrier method for firearms. But the other 2 that we hadn't really talked about, because for the younger kids, we really focused on firearms, was around medications and alcohol. And one of the interesting things that I always tell people about when I'm talking about this program is some of the scary things that people have in their homes. So everyone thinks of opiates or painkillers or ADHD drugs as those are really, really dangerous for kids. They think about them, they lock them up, they put them away. They don't lock things up like Tylenol. And what we know is something like an overdose of Tylenol is irreversible once the damage is done. So that's actually pretty deadly. Right now, during COVID, a lot of us had Tylenol in the home. In my house, it's locked up in the safe. So,
I'm not sure, actually. No.
No? Sorry. So we really tried to focus on those 3 aspects and making sure that people were, locking those substances up. And, one of the things that we found with firearms, 85% lethality if that's what you're using. So it made no sense for us not to target that piece alone. And so what we really did then was that, what do we do in the pediatric visit? So for the younger kids, we talked about, the dangers of firearms and locking them up. For the older kids, we also had to focus on just general depression screening, suicide screening, and depression screening. So training pediatricians on how to screen. Then making sure that they gave the appropriate advice. So the anticipatory guidance around storing these items safely and making sure that they understood the dangers of suicide and the statistics right now about how prevalent that is. The family component, making sure that the families were engaged with the teenagers and understood the challenges, and then if there was an emergent situation, making sure that those children were referred. And then for our program, we have various handouts and tools, and then if appropriate, if a family says they do have a firearm in the home that's unsecured or they have medications, making sure we provide those boxes to families. So along with that, we actually sat down some parents and we sat down some teens and we came up with some handouts. Folks like Dr. Ackerman helped us when we went through these. And it was really interesting. One piece on this, I think you can see it on the slides up close to, is there's an algorithm about when you should talk to your child about suicide. And basically what it comes out with is you always talk to your child about suicide. So people have this fear that if we don't talk about it, it will magically go away or it will magically never happen. Well, in today's internet society and today just how teens communicate, it's there, it's prevalent. Hiding from it isn't going to help. So really kind of pushing parents along the lines of, you do need to address this with your kids. Before we started this program, I had no idea the severity of what we were looking at. Now that I know that, I talked to all my friends about it, and my kids and I have had lots of conversations about this topic. And then for the teens, we really gathered some teens together. So we pulled teens from some more at-risk neighborhoods and some more affluent neighborhoods and kind of got them together and said, again, like we did with the firearm safety talk in the beginning, what are the common ground here? Well, the triggers were all the same. The bullying that we talked about, the isolation right now during COVID has been a big issue. But then what do you do? So a lot of these kids felt they could handle it themselves. They think that they, can watch something on TikTok and then therefore help their friends get through something like this. And we really wanted to make sure teens knew that they needed to go to a trusted adult. It might not be mom or dad. It could be a teacher. It could be a counselor. It could be just someone that you trust in your community. And making sure that they understood they needed to involve an adult. This isn't something that a teen should handle. And then really kind of going just some common ways, 10 ways to kind of take a break if you're feeling overwhelmed. The concept that, kids within an hour could be that impulsive from thought to actual completion of suicide is something we really had addressed and felt that we addressed these in these handouts, which are now all available online, and Dr. Goodham will talk about those pieces.
So what else can we do? So we're talking about, we are working with pediatricians throughout the state to screen for depression and to give out gun boxes when appropriate. What else are the other people that are engaged with teenagers? We need to engage them as well, which is one of the reasons we're here with you all today. So many of you are involved with schools. This is something that we should be discussing in schools. It should be aware. How are we going to affect that, right? As well as ourselves. We should talk about this with our teenagers. We should talk about it with our friends. I'll never forget, I don't know if many of you know Bodie Miller. He was an Olympic downhill skier. And one of his son died in a drowning unintentional injury several years ago. And I asked him about it, and he said, I sit around and I drink beers with many of my friends, and when they found out what happened, they all said to me, oh yeah, that almost happened to my child. And he said, why aren't we talking about this? And so as Melissa said, this is something we should all be talking about with our teenagers. We're involved in a pandemic right now. Firearm safety and suicide is an epidemic for our teenage population. And so we should be addressing it. So when your kid goes over to another child's house, do they have a firearm in that house? Is it secure? Do they know how to get to it? These are conversations we should feel free to talk about with our friends and our teenagers. So what we're asking people to do is take a pledge. And the reason why is we're asking our pediatricians to take the pledge because we want them to use our resources, but we'd also like all of you, we'd like teachers, we'd like people that work in community centers to take the pledge with us. They can get our handouts, they can give them all out to children and teenagers, they can give them out to other family members, because this is something that we want to spread all throughout the state. This is a billboard that we were fortunate to get up in the Akron area. And so, as I said, we're really trying to push this message because just like click it or ticket, this is something that we need to have for all of our teenage population. And with that, I will turn it over to Dr. Akron.
Thank you. Such a wealth of information. Thank you so much for that presentation. We do have the slides available if anybody would want them, so please let me know. We want to switch gears a little bit and just have more of a discussion and hear a little bit about the work that you're doing, Dr. Ackerman. I have hundreds of questions for you, but before I start on them, just an opportunity to share or jump in on anything that you would like to at this point.
Sure. Hopefully you can hear me okay. I just would first of all like to thank Dr. Gettleman and Melissa for this wonderful work that you're doing at Ohio AAP. I think this is a tremendous opportunity to engage our medical providers, but also ensure that we're getting this message to those who need it the most, which is the families. I think a couple of things that stood out to me is that the rates are very high among individuals, among children who are experiencing anxiety, depression, and thoughts of suicide, and even making attempts. But we're still very reluctant to have these conversations, and this doesn't show up in many other areas. I can tell you, having worked with individuals in elementary schools, middle schools, high schoolers, our kids are very capable of having these conversations, and they understand that these things do impact their friends and themselves. I happen to have a 6 and 9-year-old daughter. I do speak to them a little bit differently than I would speak to high schoolers, but they can understand that people do struggle with their emotional health. Some people do feel so ill and so unable to do with what matters to them that they need to involve medical care, that there are treatments that work out there, and that it's important to be able to talk about this. One of the things that's really important too is I don't think we're going to solve this just by making sure that everyone who needs emergency treatment or crisis treatment is going to be something that universally addresses this problem. We have rates that are going up year after year. This current year probably won't look a whole lot better for the risk factors that were mentioned and the trends that we're seeing. But there are really nice opportunities and solutions to get ahead of this that we haven't had the collective will to do, and we haven't implemented the safety measures that we know work. And I think the Store Safe program is one of those really key initiatives that's going to help people in the immediate risk time period address that really effectively. But I'll talk a little bit just in the course of our panel discussion. I have formal slides developed for today, just in the interest of getting feedback from participants. But one of the things that we know works is to make sure that we do have information out to young people about what to look for, how to respond, how to reach out for help, and to know when that's important. But it's also important to know that this isn't about scaring people or guilting or shaming people into action. What we know is that a lot of parents, some who have lost loved ones to suicide, haven't known much about what is going on. We know actually that only about a quarter of kids who are experiencing suicidal thoughts are going to proactively reach out to parents, for example, and talk about this. So what we need is a much broader safety net. We need physicians being involved. We need our community taking action, our faith-based communities, our teachers, our coaches, our mentors in different ways. We need actually a number of people to help run that safety net. I think that's how we're going to make the biggest impact, is to have a greater comfort level of all people who are working with kids, being able to ask very direct questions, if they're noticing what these warning signs are, being able to say, have you had thoughts about killing yourself? Is suicide something that's crossed your mind? This is something that's very uncomfortable for us to talk about when we think about kids who have what we think is a long, productive, and healthy life ahead of them. But it's something that we know works, and actually, instead of increasing tension or increasing the chances of someone taking their life, it can greatly reduce it. It can start the pathway to getting help and to starting that hope. So with that, I just would also like to appreciate the opportunity to be here with Healthy New Albany and being here at the Life Center with some great colleagues at Ohio AAP.
Thank you. Thank you very much for that. We have a lot of questions, like I said, but I wanted to discuss, and this is open, any of these questions are open to panelists, so jump in as you like. Can you discuss what it means to have an upstream approach to mental health and suicide prevention?
The way you talk about upstream approach. I look at it as, there's that old proverb, which I won't get right, but the best chance of catching the fish is upstream rather than when they've all gotten loose downstream. And it's the same for all preventative things. Prevention actually works. So if we can prevent these things from happening, we can actually see less of a problem later on. So things like, as we discussed, talking about it, making it open, trying to figure out what the triggers are so we can address those triggers, making sure that lethal means aren't accessible to them. So even if they have these thoughts, they don't have access to be able to complete. So all these things that we could do to prevent it, we're going to be so much better off. And so that's where we should be putting a lot of our efforts. Unfortunately, we have so many kids that have already expressed and have problems, so they need services. So we have to put a lot of time and effort into that. But that doesn't mean that we shouldn't put as much time and effort into the prevention so that we can reduce services and needs later on.
If I could just add to that, I mean, I think with suicide prevention, it really does need to be upstream. We are dealing with kids who are struggling at times with very intense emotions, not able to help manage them and regulate what they're going through or have the language to express what they need. And if you don't have that, then there's a real gap in accessing the care that's available. So we're starting to learn which treatments are most effective specifically for suicide, but to even get there, you have to have kids that have a vocabulary, that understand what to do with those big emotions, and then get to the point where they're not seeing themselves as a failure, as a burden, or as someone who doesn't deserve help. And these are very common with depression and thoughts of suicide, that you don't even think that you deserve this help, and that actually the world would be better off without you. And I've worked with enough kids who I know are amazing, like valedictorians, athletes, and just regular kids who deserve this love. And they think that they truly would be better off, and the world would be better if they weren't in it. So being able to help people put a understanding to this can happen to you. It's not something is bad or wrong with you. You're experiencing sort of a brain illness process, and the kids can understand that. But we need to make sure it's not something that's stigmatized, and people who experience this are pushed away. It's very healthy, very productive, and really everyone can go through this. Suicide does not discriminate.
We talked quite a bit before the panel, just so I could kind of get an understanding of the work that each of you do. And in that discussion that we had, Dr. Ackerman, there was one sentence that I wrote, and it shocked me, and I want to talk about it. And it's a difficult discussion, but we talk about sometimes how we call our small communities like New Albany or Arlington or Bexley or some of these other places. We call it the bubble. And you actually said you were horrified by the word. And I agree in a lot of respects. And I'm wondering if we can talk a little bit about that, because I feel like in some respects it gets right to the heart of what you were just saying, that it's a hard conversation to have, and there is stigma around it, and we have to be the ones to begin to break that. So why does the bubble connote a negative feeling for you?
So in full disclosure, I also come from Upper Arlington, and they label themselves a bubble, and some people say that with a point of pride, and I really tend not to, because I think part of what we need our kids to do is to understand sort of the individual differences in the world around them, and then actually reaching out and serving others and making sure there's opportunities to understand those unique perspectives. Not only is healthy for the communities you're working with, but it's also thinking outside yourself, and especially if you're struggling with depression or anxiety. One of the core traits is you're internalizing, you're focusing that spotlight on yourself and how you're measuring up or not measuring up to others, whether your standards are fitting what you believe in yourself. And so making sure you've got that opportunity to reach out, serving others is a huge way to actually reduce things like those internalizing symptoms. And I do think that especially during a time of pandemic and a time where it's so easy to focus on everything that is wrong, we actually need to help our young people focus their attention outward and giving back and finding other ways to connect. So there's nothing inherently wrong with a community that wants to thrive and make sure their kids are doing as well as possible. I just think part of that involves a focus outside of those smaller groups and making sure there's opportunities to understand the world in a bigger context.
Absolutely. Yes, and I feel that definitely just from participating with the food pantry. You go volunteer for 1 hour at the food pantry. When you walk out the door, you feel like a different person. And I think that conveys to kids as well. They feel the same way in helping others. We talked a little bit also about high functioning communities, super high functioning communities, and how that causes stress. I know that I have kids of my own in the schools, and we have an awesome, wonderful school system, and it's hard on them. And we have a lot of high achieving kids. So is that a piece of this discussion about being high functioning or high achieving?
So I think some people might be surprised that as a suicide prevention person, I'm going to actually suggest that it's not exactly the stress that our schools and communities place on young kids that's the bigger issue here. We've had high expectations for kids in many communities for a long time, and that's not exactly what's changing. I think what's changing is the preparedness that kids have and the social support and the disconnection that's in a lot of these situations that leave kids without necessarily sort of the pathway and the ability to talk to other people in a way that can meet their needs when they are distressed. So I think if we start at a place letting people know you will encounter times when you're overwhelmed, you're upset, and there are ways to navigate those difficult feelings, and there's people to reach out to, and there's actions you can take when you're in that situation that's going to help kids feel less trapped. And so I think sometimes you need to really reach in when you see that, but also helping our kids know that there are steps they can take, and everyone should have a plan. I think that's another thing we kind of miss out from a hospital perspective. I'll speak from that. One thing we do if there's suicide risk is we safety plan. We make sure that there's people to talk to, there's places to go, there's ways to distract oneself through a crisis. These are incredibly effective interventions. However, I think we sometimes wait too long, and we actually have to let kids reach out before they reach that point. It's a lot better to have a low-level intervention, perhaps it could be an outpatient crisis or just a traditional therapy setup, that we'd rather have before we get to the point of a crisis where a young person has attempted suicide.
I'll also add, though, I think it's important that it's not just high functioning kids as a stress, and kind of as we were presenting, every kid is at risk. It's not kids that are just high functioning or not just kids inner city, or every kid has stressors upon them, and how resilient they are and how they deal with it is completely different. So that's why you have to assume every teenager is at risk. Have these conversations, start to weed out some of these stressors and see how we can help them. I think that's the most important thing. When you start brandishing and saying, well, it's not our community, or it's not our problem, or it's not our child, then you're missing the boat. You always have to think that there's a risk.
And we've been talking a lot here just at Healthy New Albany about what we do and how we intervene and what's the process and how do we build this larger safety net that incorporates the teachers and the coaches and the mentors in the schools. And we've been talking about direct therapy because, for instance, in speaking with some of the therapists in the community, they love the prevention and they love the education, but they want to understand how their kids can get serviced. And so I know we kind of talked about this, and we're definitely working on our side through Nationwide Children's to bring some of those services to bear here. So for sure, that is on our list to do. But again, something you said in our discussion that I think we have to talk about is we will never hire enough therapists to meet the need. There's a capacity issue. So maybe can we talk about that, and then what we can do to, in the forefront, so we're not at the crisis stage when we are looking for those services.
Yeah, I mean, I'll just reiterate that we do not have enough providers, period, at Nationwide Children's Hospital, at Concord, at Centero, at any of the providers that you could go through the list. We would need, if we took the numbers that were shared with us, the number, just the people in a given year who have thought actively about ending their lives, we would not have enough providers. That's why we need, I think, a much more diverse stream of prevention strategies and intervention strategies, and not all of them might involve one-to-one therapy. I think we need to think about creating, maybe it's algorithms or other strategies to make sure those who need high levels of help absolutely get them. Those who need crisis services and interventions are getting them. And then we have different tiers where we're using more adaptive technology to get kids who could actually go through a series of interventions whether it be online or through other options with some guidance. And I wouldn't have said that 10 years ago, frankly, because I don't think we truly understood the scope of the problem. And individual therapy, as a psychologist myself, I think there are evidence-based treatments that really do need to be brought to bear on high-level or moderate to high-risk kids or those with long-standing depression and anxiety. So I think we need to just find more opportunities to meet kids where they are. I'm a big fan of integrated primary care psychology, for example, having providers. It doesn't have to be a psychologist, but having a mental health provider in primary care practices, for example, having school-based mental health services where within the schools that you're trying to break down the barriers. So I think we need more mental health support in the places where kids are. But we also need more providers. And I'll also suggest that we are working hard at Nationwide Children's Hospital, but every service provider needs to have a lot more training and support in addressing youth suicide risk across this country. There's a real gap in what the training looks like to do evidence-based practices in suicide care. So it doesn't mean that there aren't effective treatments, because there are, but we still have a ways to go, even professionally, to get there.
And I think, there is some training that can be done with providers, especially primary care, around things like, depression screening. Like, 2 or 3 years ago, very few were doing that. It's pretty simple. It's, they're evidence-based screens, and then training, primary care providers around medication management, also pretty straightforward. So for those kids who are not in crisis mode, but, are struggling a little bit, kind of getting with them early and making sure that they have access to that early on. So that, the providers that, the child psychologists out there who, these kids who need intensive therapy, they need to have those spots reserved for some of those kids. So sometimes you can handle, some of these kids who are just starting to experience a little bit of depression early on in primary care. And then we've also seen some success now in even looking much younger. So when you really want to talk about going upstream, thinking about trauma-informed care, thinking about, ACEs screening, thinking about, these kids and what happens to them when they're young. And then what do we need to do to build their resiliency at that point? And again, that's not necessarily using counselors. It might be using teachers. It might be educating home visitors or community health workers or others who might intervene in that child.
Could you share, I know you spoke a little bit about that, Dr. Ackerman, about the program that you were working with I think 3rd to 5th graders? Yeah, and I'll just talk briefly about it, but we support right now about 167 schools in Central and Southeast Ohio using something called the Signs of Suicide program. I know that's actually been used in all of these schools in the past as well. It helps educate kids what to look out for. It helps educate staff knowing how to intervene, how to ask direct questions, and it goes through different scenarios that a young person might find themselves in. So one of our projects that we're involved in right now is to actually support specific developmentally appropriate programming for 3rd to 5th graders, because there is a gap. What we're finding is a lot of the current research suggests that about 6% of 9 to 10-year-olds have thoughts of suicidal ideation, and 1% have made a suicide attempt. So by waiting until high school, we all really waited too long to have these important discussions. So I'm going to kind of default to absolutely we should be having these conversations in high school, but middle school is probably a little late to first have these conversations. And late elementary school, specifically around suicide, is where we need to start to begin to have developmentally appropriate, concrete, not overwhelming discussions. But we want to make sure that kids know what to say, how to get the help. And this program that we're actually working with a company that does developmentally appropriate curriculum. I'm not sure if you already does .day, but there's sort of international .day that works with young kids about how to learn, how to express themselves really appropriately. But it's groups that do really good learning materials for young kids, and I work with other programs to make sure we can have this discussion in a way that's most appropriate. Can you explain and discuss the importance of social emotional learning? That's probably a big topic. I don't want to take over the entire discussion. Really, I will get back to the point we made earlier, is that kids have the ability to learn how to express themselves in a way that gets their needs met
if they are taught these skills. These skills can absolutely be taught in schools at a very young age, and most school systems should try to think about how their social emotional learning continuum fits with the needs of their community. And I think that most school systems are there. I know Albany cares a lot about that area, so I can't speak to specific programming, but it basically teaches skills like how to identify emotions, how to work with other people effectively, how to manage distress, how to get through challenging situations using the types of skills that we know work. So I think that is a way to go way upstream, and it might not say suicide prevention on the booklet, but it absolutely is. And these are the skills that we need to work. And there are other things like having supportive adults, making sure you have at least one strong connection in the school, making sure you have a life that has meaning and it's worth living, and that you can have conversations about that. And when you're depressed, doing more of the things that bring you joy and bring you value, even when internally you don't feel like anything brings you joy, is something that we would also encourage.
Well, and that was another part of the discussion that was so interesting to me when we talked. And just you shared, you will do a much better job than I will, but just the discussion about belonging and validating a child and how powerful that is.
Yeah, if you looked at a lot of the risk factors that Dr. Gettleman shared, a lot of them have to do with feeling invalidated for who you are as a person. If you look at things like abuse, neglect, rejection because of sexual orientation, gender identity, family history of loss and stigma and things like that, all of these things are things that intensify suicide risk. So some of the things that we need to do are make sure that we have opportunities for kids to feel validated just for who they are. It seems almost cliche and simple, but I think we need to think about, we can save lives by making sure kids have their identity validated for who they are and what they do. This doesn't even mean as an adult you need to agree with those values, or you need to say this is what every kid should be able to do. You need to be able to, from a suicide prevention perspective, you need to be able to validate that person's life. And that, again, it doesn't even have to be agreement, just being there and having adults and making sure they can link with other adults who can value them is huge for kids.
Yeah, I walked away from that conversation thinking, oh my gosh, it's so simple and it's so obvious and intuitive and it's easy to do. We can all, I have so many parents, what do we do? What are the interventions? What should we be doing? That is such an easy thing you can do every day with your child. So I love that because it's so manageable and achievable for all of us.
And I'll add to that it's not only for suicide, it's for all other mental health disorders.
Right.
I mean, especially these younger kids in our emergency department, we see a lot of increased aggression. We have punching walls, breaking things up. Families don't know what to do, so they bring them into the emergency room. Or feelings of just complete depression, or acting out in school, and the school says, you need to be evaluated. At that time, these kids don't have suicidal ideation, they're just acting out. But if you give them these kind of resources early on, you'll prevent things later on that's going to cause problems.
So powerful. That was another statistic when we talked about earlier, that there were 600 hospital admissions per month. And suicide is the #1 leading, or attempts would be the #1 leading cause of hospital admissions. And it's 1 in every 10 ER visits. Do I have those facts right?
Yeah.
So that's something that we've talked about internally then. Once a child has an attempt and they go into the ER, I guess first we need to figure out how to prevent that. But the second piece is, it seems like there's somewhat of a disconnect once they're released. Like, what happens once that terrible event happens and they go into the ER and then they go home? Is there a plan? What can happen to kind of move that child to a better place after that event?
I can start and then, because I'd probably hand it off to you anyway. But when I see them in the emergency department, are they at risk? And one of the problems that we have is there are not a lot of services available, and kids come in crisis, and in that time, there is a risk. And so as a result, it's very hard. They come in, we see them in a short period. We can't just say, good, tomorrow you have an appointment. They might not have an appointment for a month. And so what do? We have to admit them to the hospital so we can get them services, kind of let things calm down and see what the situation is. And then once they're discharged from either the emergency department and or hospitalization, well, then they need services. But some of the problems that come in are, we still need to get them into service. And I would say nationwide, the Cincinnati Children's and a lot of other institutions caring for kids have expanded services astronomically to be able to get kids in the next day, maybe have a day program to get them into more intensive therapy, but they don't stay there overnight. Work with things in the home to try and help them out. So there are a lot of things that are put into place, but I think the other problem, and you could probably address this more, is families feel that you were in the hospital, you're better. Or there's a quick fix, you can take this medicine, they're better. And it doesn't work that way. This is a long-term problem. It's kind of like the alcoholic. You don't just get better after going to AA for 3 visits. This is something you deal with every day. And it's very similar. This is a long-term problem that you have to deal on every day. It's not like you go home and everything's better. I see that a lot. People come back to the ER and they say, they were just admitted a week ago, nothing's changed. We have to work on it.
Yeah, you really couldn't have said that better, is that the expectation, I think, of a lot of families is that this emotional crisis is almost like having an accident or you've broken a bone and we went to the hospital and it got fixed. And now let's resume where we were. But typically, especially with emotional health issues, they've been developing, they fluctuate up and down. Actual suicide risk is super hard to predict in the first place, which is why we do all this screening. But what we have is individuals who leave this hospital setting, and sometimes there's a false sense of security. In fact, we know that the highest risk period of time for a young person who's experiencing some level of suicide risk is the day after they're discharged. The second highest period of time of dying by suicide is the second day after leaving the hospital. So I think there's a disconnect between thinking that heightened intervention did everything that's going to be needed over time. So we have some strategies in place after anyone who's been discharged or receiving care, because you're not addressing all of those complex needs. Suicide is very complex. It usually involves underlying mental health conditions, other risk factors, lots of changes. So we need to address some of them in the short term and make sure that we're empowering that young person and their family to reach out when they need it and to use these higher level services in a way that gets their needs met without, you can't mandate that everyone stays in the hospital, nor would we want to. We would create other problems by doing that. But we want to make sure that they feel valued, that they know who to reach out to, that they have immediate support both in the home, and then very, very importantly, and one of the reasons why we're here is to make sure that for that foreseeable future, their environment is safe. So if they have those thoughts of wanting to die, which are fairly likely after just being admitted to, it doesn't mean they're in need of rehospitalization if they're having these thoughts. If they have these thoughts and they can't keep themselves safe, if they can't use their safety plan, if they can't navigate the use of their skills, then it might need to be readmitted. But our goal is to make sure that there's a good plan in place, that the things that they could use to kill themselves aren't accessible in the short term, build that bridge from crisis to hope, and then make sure that they have a reliable system in place to support them. So we also send out something called caring contacts. So we have, if a family's okay with it, and their child's 13 years and up and has a cell phone, we actually send their child text messages the day after discharge that has messages about how they can get help, why they are valued just for who they are, and then they get those every week for the next month, and then monthly for the next 3 months. So we want them to just hear the message that you're on this journey. This has got to be very painful for you, but there are people who care about you, and that you are important and your life is important just for being who you are, not because you're accomplishing something, not because of anything like that. And so it's one small way. Actually, it's got some powerful data behind that. That seems so simple. Like we have these complex interventions that have some data of effectiveness, but these, what we call caring contacts, actually have a decent amount of effectiveness. It's not going to cure a young person, but it helps let them know that their life matters.
Is that something we could do as parents even? Maybe our children aren't in a caring contacts program, but could we almost think, gosh, who would my child reach out to for support? And then kind of back into that, like begin to cultivate those relationships, or maybe even having those discussions with, if you were ever in a crisis or you were ever feeling whatever, who would you call? I mean, would you have those discussions and almost get kind of a checklist of 2 or 3 people that your child could contact?
Yeah, I mean, I think it's a great idea to be prepared in advance. I think the main piece that as a parent that you probably have the most control of is building that foundation with your child, and to ask them direct questions about their emotional health, and even ask them as they're getting older whether they've ever considered suicide. These aren't necessarily questions that you would just ask out of the blue. You want to build a foundation. My recommendation that would work, as we talked about for many mental health conditions, would be setting aside individual time where you let your child take the lead and you let them express what's going on. You're not demanding of them. You're not telling them you need to do X, Y, or Z. You're setting aside this time. It's just dedicated to them being in control of that, either that play or that conversation, and learning that it's okay for me to get into this space where I talk about strong emotions. And as a parent, you're letting them know that they are brave and strong for sharing this. And that will teach them, if they do have a crisis, not only will it probably mitigate the chances that they do have a crisis in the first place, because they have this openness and this space to work in, but they know that you'll be there for them when they have something that is stressful. And I think that's really important for kids to know. And it actually is a prevention tool.
And then, of course, even just like you said, preventing those barriers, locking up the guns and the alcohol and that, to make sure that that's not an option in a time of crisis or something like that.
And medicine, I would say that's super common. We actually worked with Poison Control to publish a paper that had some national data that actually was suggesting it's that over-the-counter medicines and ADHD medicines and a lot of the things that parents are much more comfortable letting their kids self-administer or have out and locked up. Those can be, again, kids will, the lesson we learn is that kids will take advantage of whatever is accessible in their environment. And we know that because parents don't often know, they make assumptions. So we're not here blaming parents if anyone who's had a child with a suicide attempt did something horribly wrong. We're suggesting everyone needs to take these universal precautions, because you can't always tell unless you have these very direct conversations. And suicide risk changes over time. So even if you ask that once, that could change as well. So unfortunately, the data has convinced me we have to be much more proactive about locking these things up. And that's one thing that is going to save lives.
Mm-hmm. And if a family's watching here today and they want to get some information about taking the pledge and getting these devices, what would you recommend for them?
One, I would recommend taking the pledge because you can have availability of resources. Two, I would say start having these conversations. You know, just as Dr. Ackerman said, one of the things I like to do personally is we have family dinners. And every night we have a dinner. At dinner, we talk about how the day was, showing your child that you care about them, making sure that you're engaged in their activities, going to their activities, showing them that it's non-judgmental for them to come to you with problems. I mean, they have to have some type of resource or base that they feel comfortable to go to. And if it's not you, then yes, having some peers that they can also check in on them. I mean, having that group that's going to help each one of your children, I think is really important. But having those conversations, having the resources, and then I'd say lastly is, just as you would laugh if you said, I have a toddler and I didn't home-proof my house, right? Like you would, you don't proof your house, you'd say, I don't want them to get cut on the corner of the table, and I'd lock up the electrical outlets and I'd put the medicines away. Well, now we're talking about a older toddler, the teenager, that's incredibly impulsive. So I would make sure that anything that they could get in touch of that could harm them is locked away from them at all times.
And the pledge is something a child takes and the parent, they do this together?
Yeah, you can point, and healthcare providers can, community members can take it. It's just really about having access to resources. And then pediatricians right now across Ohio are applying for these gun boxes. So I meant to bring one today, and actually we switched cars, so it's sitting in my car, so it's not doing as good today. But it's not very big. I mean, these boxes are about this big. I mean, they probably look like a novel, like a hardback novel. They come with a simple key lock, and then they also have like a cord, so you can put it around something. If you are worried that it could walk out of the house, you can put it around a bed, or some people put them in their car. But they're just kind of a simple box, and then pediatricians will be basically asking us for them through a grant process, like a really, really simple grant process. And then we'll get those distributed out across the state of Ohio. So hopefully a lot of people will have access to these gun boxes for free through their pediatrician.
Pediatricians, got it.
And I'd also just like to add, so when you look at unintentional injuries as a whole, they often happen when things are out of your routine. So in your routine, you might lock up things in your house. You might have everything totally home-proof, and then you go to the cousin's house for Christmas, or the kids after school couldn't get to your house, so you go to grandmom's house. And we don't think about making sure that those areas are secure too. So it's really important that if grandma has guns in her house, if grandma has medicines, that those are locked up, because those teenagers are incredibly resourceful and they know where things are. So at friends' houses, others' houses, it's really important to practice the same way that you would in your house.
That's really good advice. I would just say from, kind of the psychology part of this is that a lot of what we've asked you all to consider are difficult conversations that you may worry about how others feel about you, like you talk to grandma or a friend and say, I need to ask you this tough question. Do you have a firearm in your home, and how do you store it, and these things? So you might have to practice, or asking your child, have you ever had thoughts about ending your life? And these things that just feel so awkward and create this tension inside of you, you might have to practice in front of a mirror. You might have to talk to your friends or a significant other. How are we going to have this conversation? Are people going to think less of us? But at the end of the day, almost everyone who's probably tuned in here, and everyone who's a provider, cares deeply about child safety, and that hopefully can override some of those discomforts and like I said, some of the other thoughts buzzing around in the back. If we can think about that's our priority, and if maybe we sound stupid to someone, or maybe we're overreacting, I'll take that 100 times out of 100.
Absolutely. One of our practitioners sent forward a question, because they get this question a lot in their practice, and that is it okay to just straight out ask my child if she or he is thinking about suicide, or will this give him or her the idea?
That's an easy one. Data is super clear. There's been multiple studies. You can ask kids directly about suicide without increasing their distress. In fact, some studies would suggest by asking them that, if they are thinking about suicide, you've given them an opportunity to talk to a trusted adult, and their stress level is reducing. So there's point you to that research. It's really strong.
Awesome. Another one that came from a practitioner is, how do you know when teens are just being dramatic or craving attention and not really suicidal? Or is this something I need to be concerned about every time?
It's really hard. You just don't know. And the numbers are so high, I would take everyone very seriously. So this is not something that, I've heard this before, or, she always says these things. She's just dramatic. She's saying it, take it seriously, have those discussions, because it's really important.
Yeah, I'll just add, there was some really good research done really decades ago showing that our gut is not wonderful at predicting these things. We can't eyeball people and tell whether someone's just doing this for attention or has underlying reasons. So we ask every single time. And the way I think about it is, if they are in great distress, we need to respond appropriately and give them the support. If they're not, then there's an issue with the way they're expressing themselves to get their needs met, and we need to help them with that piece of it. So either way, we either need to help them express their frustration and distress better, and getting their needs met better, or we have a much more significant issue and we need to address that immediately and with urgency. So either way, you're going to address it. It's just might need to learn more and lean in and listen.
And I would just also say too that everything doesn't have to be, you take it to the nth degree. So if someone expresses it, it doesn't mean all of a sudden I'm rushing into the emergency room. It means that you start having a conversation and you start trying to understand why they said it and what they meant. So it's really important to always have these conversations, figuring out, is this something of utmost importance and urgency now? Or is this something that maybe I can just call the hotline and get understanding, or maybe they have a therapist I can call them. Not everyone needs to be rushed when you hear it every time to a
Yeah, we in our school programs, we've screened nearly 50,000 kids, and less than 200 of those have actually needed urgent crisis care or hospital level care, and really actually nearly 9,000 of them said they did have some level of suicide risk. So if you're talking about, do we send everyone to the hospital who says I've had thoughts of suicide? Absolutely not. We need to evaluate that. We do a risk assessment and a safety plan, and those who have urgent needs, can't safety plan, have ongoing urgent needs. That's a different story. But I do think we can have that conversation without escalating to the highest degree, as Dr. Gelman said.
Can you discuss, and I know this is probably an entire hour-long topic, but just briefly, maybe the considerations around social media, just for kids in general, and how it affects their mental health or depression or comparing one another, or that's a big can of worms right there. In 20 words or less.
my 2 cents. The way I think about it is social media is a tool. Kids are going to be using social media. That's how part of their lives revolve around connecting with others. But that said, there are some data that suggests overuse of social media is problematic. Once you get past 4, 5, 6 hours a day, there's a lot of diminishing returns that potentially contributing to anxiety and depression. But it does depend on how kids use social media. Some kids use social media to be advocates, to learn how to connect with others in more deep ways, or sort of support a cause. And that actually doesn't have a lot of data suggesting that high use of that is problematic. But what kids do, even more so, are young girls. They spend time engaging in social comparison. So they're determining whether they're stacking up to other people, whether they're having as much fun or they're looking as good, or they're doing X, Y, and Z. That is associated with reduced mental health outcomes. So we do want to have conversations with how our kids are spending their time on social media, what it looks like, and then I've got young kids. They're we're gonna have they don't use really any social media now at 6 and 9, but it's really going to be limited to probably less than an hour for the foreseeable future. And just, at a certain point, late high school, you don't have to stay controlled, nor should you, because they're developmentally different. But having conversations about how they spend their time and how it makes them feel to be on these platforms is really important.
I would say I have an end of just my 2 children, but when they were teenagers, I actually asked them that question, and I said, why is social media such a problem? And it was really interesting. Their response was twofold. The first was it causes isolationism. So we used to be able to not have a phone, and we'd all be in a room, and we'd talk and engage, we'd see faces and smile, and now we're in our room just typing, and so we are really alone. Okay, and then the other part is similar to the comparisons is so-and-so's having a party and everyone's going and I wasn't invited. And so you feel even more alone, and you feel like there's this comparisons and everyone's always having a better time than you. And the combination of being alone and feeling that everyone's better than you causes some of these problems. And so I think that getting off of the screen, having more interactions with kids in physical appearance after COVID and other stuff, happened. But there are things that we can do to affect it besides trying to look at their phones and troll all the time.
Yeah, and I think, what are you not doing if you're spending 6 hours, 10 hours a day gaming or on social media? You're not being physically active, which we know has tons of health benefits. You're not probably regulating your sleep very well. Sleep and mental health have a pretty significant correlation. And then, what are you doing in terms of that time? That face-to-face contact does have good mental health benefits as well, for that eye-to-eye contact that you're not getting. Some kids navigate it well, some kids struggle, so it's not everyone's affected the same way, which makes it hard to make these blanket statements, but you are better off making sure that there's a conversation in person and if you can, but we're in a pandemic, so we're all figuring it out.
Well, I think the other thing that we always talk about is there's no ability for them a lot of times to walk away. So if you're talking about a bullying situation or just stress from school or even, my friend is doing better than I am. All of those, it's kind of like all of us, right? Now that we have smartphones and computers and access, even leaving work, you can leave your work day, but a lot of times your work day doesn't leave you. It can go on and on and on. These kids have that same problem and don't regulate that very well. And so it used to be, if you were, getting along with one of your, peers in school, you were able to leave that situation, go home, at least, be around your parents or some other caregivers and have that time and that break. You don't have that break anymore.
Yeah.
So I think that open dialogue and discussion with your kids of, come to me and have that conversation. If you're stressed out, you need to talk to me. Like Dr. Gittleman said, if it's dinner, if you can have that conversation over dinner, that someone's doing that, you're trying to get a window into what's actually going on your screen without necessarily seeing it, because it's not like it used to be where it was just text and emails. Now it's Snapchat and images that disappear. So you can't even as a parent monitor some of that because it's no longer there for you to see. You have no idea what was said to your child.
True. We have many more questions, but I wanted to give an opportunity for any audience questions, if there are any. Yes, please. You can, yeah, I'll switch with you, or if you want to.
I'm a recently retired pediatrician, so I've been in the trenches forever and a day. And this is a wonderful, outstanding presentation. You really won't find anything like this anywhere. They don't know it, but they did a great job. I have a couple comments. One is for the last year of asking, last 10 years of asking families about where they, whether they have guns or not in Central Ohio. About 50% of my patients have guns at home. Almost all of them have had it locked up. For those that don't, I try to get them to lock it up. This is before this program. I have found that the electronic health record is wonderful as a reminder in getting guns locked up for people, because you come back to them and you find that what I found is a lot of them will lock them up. It depends how you present what you want to share with them. So form is as important as context. The second thing is that I find pairing this with resilience to be the most important thing. And I push families to attend Ginsberg's books on resilience from the American Academy of Pediatrics. This fourth edition of this book is just excellent, and it's a nice way to pair, especially during COVID time, what is going on in their worlds, and to try to get them to have meaningful experiences and be resilient through this horrific pandemic and other horrific things that are going on. And I absolutely agree with dinner time. And the right word is non-judgmental, because that's where one has a really good time to communicate with their families. So I didn't really have much in the way of questions. And also your point about serving others or volunteering, as long as it's not for padding college applications, which is what it often is. It helps to get people out of their own skins. So I'm just sharing this as a primary care pediatrician who's recently retired, and so I'm very fortunate to have this today.
Thank you.
Give your word.
As we close and wrap up, we are going to be partnering with American Academy of Pediatrics and NCH as well, and other local experts, just to provide information and resources and some more support of the local community needs. So we will definitely be staying in touch. We also have two representatives here today that are actively working in the community. Diane Herman with the New Albany Plain Local Schools Wellbeing Community liaison. She's the community liaison. And then James Gillis from Integro and HeartMath. If you would you want to come up and just give a quick, yeah, we'll just give a couple moments so they can share locally what's happening in the community. We want to make sure all these resources are provided. Thanks.
Again, thank you, Angela, and Healthy New Albany, for having us here today. Thank you all for your wonderful presentation. Really learned a lot. As Angela said, my name is Diane Herman. I am the Wellbeing Community Liaison for New Albany Plain Local Schools. I'm here with John Hood, who is our Director of Student Services, Safety and Security, and Patrick Alloway, our Director of Communications. At New Albany Schools, well-being is held at the highest regard, the same level as curriculum, instruction, and assessment. Our well-being initiative was founded several years ago now with the mission to empower a caring community with resources that maximize the mental and physical well-being of each student. To do this, we identified the gaps or the needs in our school, and then we find the best-in-class evidence-based programs to help meet these needs and then measure the outcomes. We have nearly 20 programs and initiatives that we're leading. We have things at the youngest age, zones of regulation, to kind of help with some of the things that we started talking about today. We do signs of suicide with our 7th and 10th graders, and we're in the process of that. Those surveys are great, and that is continuing to happen even with our VLP students this year. Also, we have a daily partnership with Concord Prevention Counselors, and they are in all of our buildings to help do some of the prevention measures necessary to help all of our students. We also have a Sources of Strength program in our middle school and high school. And this program is an evidence-based program, and it helps to prevent suicide by increasing the help-seeking behaviors of students and promoting connections with trusted adults. And we are looking into implementing this also with our younger students. So these programs, we think, are some of the ones that we are trying to do in our schools to help with these issues that our whole community is facing. So thank you very much.
Next is James Gillis, and he's going to talk a little bit about Integral, the work they're doing there, and Heart Math.
Hey, thanks for having me. James Gillis, and I'm with Integral. We take a holistic approach to stress management, emotional fitness. 2 areas we like to focus on is sound therapy. And one thing all of our providers have is we're all certified Heart Math providers. Heart Math is an institute in California that has developed a emotional fitness stress management program. We are all certified to teach those tools. We actually have 3 coaches on the team, myself included, that are certified to teach the Smart Brain, Wise Heart program for kids 6 and up. It's an interactive program. It's all evidence-based. And it's all based off of Heart Math's Resilience Advantage program for adults. We found that with just 5 minutes of practice a day using these tools delivered in this program, you're able to reduce anxiety by 46% and depression by 56%. Like I said, it's a California-based program, so it's really just now starting to pick up in Ohio. We've recently trained with the ONA, the Ohio Nurses Association, and Heart Math is also part of the services offered to students at the Wellness Center at the Ohio State University. And we're also happy to say that we're partnering with Healthy New Albany to offer Heart Math as a program in March. So, yeah.
Excited.
Thanks a lot for having me, and just want to let everybody know about some of the things we're doing at the Still Wellness building.
Thank you.
Thank you.
Thank you, everyone. We wanted to provide some local resources, just so you know, we're not just here to talk about this and go back to our regular daily lives as scheduled. We want you to know as a community that we're here as a resource. So if there's any questions about any of the presenters today or information that you heard, please feel free to reach out to us here at Healthy New Albany. We hope to connect you with those resources. Again, somebody that she couldn't be here today, Christy Deere, and this information was in your packet, and you also received it electronically. She is working in New Albany and doing therapy and adolescent help for adolescents in our community. Wonderful. So she's somebody you could reach out to if you need it, if you have an immediate need. As James said, we will have Heart Math here every Saturday in March from 10 to 12 a.m. We are going to be continuing partnership with Nationwide Children's Hospital. In fact, in March, we will have the NCH On Your Sleeves panel discussion here. We will be talking about mental health, depression, anxiety, and breaking the stigma, primarily focused on children and adolescents. So we will have that team here in March, and we will have an ongoing partnership with Nationwide Children's to continue these discussions, as well as Ohio Academy of Pediatrics. So thank you so much for your help and discussion today. Just one other note on this Lunch and Learn series in February, next month, we will have Dr. Wando Aliwala. This is her book. She's a New Albany resident, amazing human being, OSU professor, also the professor of clinical family medicine and the chair of the Department of Family and Community Medicine at OSU Wexner Medical Center. So we're going to have a great discussion in February about her book, The Life Cycles of a First Generation Daughter. So the primary focus in February, it's Black History Month, will be diversity and focus on Black history. Thank you all for joining us today. It's been wonderful, and we look forward to seeing you again soon. Thank you.